Basically, what happens here for the most part with IBD is there's an abnormal immune response or inflammatory response. And what happens is cytokines get released. And those cytokines end up damaging the intestinal mucosa. What's going on, y'all? How y'all doing? Hope it's marvelous as always. And welcome back to the conclusion of my sub-series in 302. So this is, of course, digestive tract disorders as part of the nutritional basis of disease session series. And what we're going to go over in this one is IBD, right? And this is inflammatory bowel disease. It's an autoimmune disease and chronic also. Folks with IBD either have ulcerative colitis or they can have Crohn's disease. The common symptoms for that, much like IBS, is diarrhea, stomach pain, and tenesmus. Okay, now tenesmus can either be rectal or vesical. Basically what that means, rectal is, when we go number 2, and vesical is where we go number 1. Your bladder or your bowels is empty, but you have this sort of feeling or this need that you have to go. As of 2024, just less than 1% of Americans is affected. That amounts up to about 2.5 million, with women being the ones that experience the higher occurrences. To get into some numbers for you, even more further broken down, 0.8% non-Hispanic white, 0.5% Black and Hispanic groups, and 0.4% Asians experience this. So as you can see, non-Hispanic white folks are the ones who experience this type of disease the most. Throughout the next 10 years, it could affect more than 1% of the population. So cases are rising overseas in the Middle East, Asia, and South American regions, with numbers affecting about 7 million people globally. Just like IBS though, there is no known cause. There are theories though of how IBD, occurs or exacerbates. Usually they tie back to environmental or clinical factors, and even some involving genetic predisposition. Basically what happens here for the most part with IBD is there's an abnormal immune response or inflammatory response. And what happens is cytokines get released, and those cytokines end up damaging the intestinal mucosa. Now, allow me to define that for you so that you can help understand and put into perspective, what it is I'm about to go into, further on in this here session. So, intestinal mucosa, if you don't know what that is it's our body's, when it comes to our intestines, our digestive GI tract, I should say, our digestive system, mucosa is what our body needs in order to do things such as absorb nutrients from food that we eat, as well as fight off pathogens and harmful bacteria. Gut mucosa or intestinal mucosa, they both mean the same thing. You may hear them interchanged, but gut mucosa is what our bodies need. That's our, like our harmless bacteria. Because in our digestive tract, we need bacteria, in order to fight off the harmful bacteria. Now, what happens with gut mucosa, right? When that's damaged, as you can imagine, it affects our ability to be able to absorb nutrients, as well as, release certain digestive enzymes, to help with, mixing of food and, absorbing nutrients and processing the waste out. Our intestinal mucosa, we definitely need that, right? That helps us do, a number of different things. 40 to 50% of patients that experience this disease, they have symptoms that involve the rectum. I'm going to go into the 2 different types, Crohn's and ulcerative colitis. First, I'm going to put this figure up here, right? This is 15.14. And what it is it's the comparison between Crohn's disease and ulcerative colitis. So as you can see on the left side, that is what a normal colon looks like, right? That's our normal large intestine. As you can see on the insides, the intestinal wall is, it's thin enough as it is. As you can see, in quotation marks in the second picture for Crohn's disease, there's what's called cobblestoning. So what happens is the inflammatory response, once the inflammation heals, it tends to have a cobblestone-like look, which ends up also thickening the walls. As our intestinal walls thicken in IBD patients, what happens is, it starts to create more obstructions, which of course is bad for waste, right? As we process waste and try to absorb nutrients and whatnot, blockages occur, because as you can see, the intestinal wall is thickened, which means there's not enough of an open pathway. The thickening of the wall is a result of, and the cobblestoning, of course, as I mentioned, it's an inflammatory response. that ends up, when they heal, they turn into what's called fibrotic tissue or fibrosis. So that fibrotic tissue is essentially scar tissue, right? That's a synonym for it. And that scar tissue thickens the walls, and then you get blockage. So inflammation happens in both Crohn's and ulcerative colitis. But what happens with Crohn's, though, is the inflammatory responses are patchy, which explains the cobblestoning-like look once the inflammation heals, right? So, and also something else that can happen is fistulas in Crohn's disease. It's more common in Crohn's disease than ulcerative colitis, but fistulas can happen. Fistulas are these it's this small tunnel-like connection between two parts of your body. I'm not really sure how YouTube is gonna allow me to say this, so I'll just say something else. When it comes to women, for example, since they face this the most, the fistulas can end up creating a connection between one's bowel and the lady parts, right? A woman's lady parts. But it doesn't always have to be that. It could also be between the bowel and bladder, right? Or it could even be bladder and skin. You know what I'm saying? That's basically what it is. It creates fistulas are these little tunnel-like pathways that essentially allows for waste, fecal matter, and all of that to leak out into places where they really should not be. Now, also with Crohn's disease, right? Crohn's can affect any part of your digestive tract, or any part of your GI tract, I should say. That being from your mouth all the way to your back end. About 75% of patients with Crohn's disease, they usually present with small intestine involvement. Ulcerative colitis is a little different, right? It's still an inflammatory response, but as you can see, the inflammatory response, so in the normal picture, the intestinal wall is already thin enough as it is, right? But with ulcerative colitis, the inflammatory response, those cytokines, they damage our intestinal mucosa so much that it ends up ulcerating the mucosa, right, and the intestinal wall. And so as you can see in this picture, for ulcerative colitis, for UC, the intestinal wall is even thinner than the normal picture is, right? So it thins out completely, and oftentimes UC creates what's called a toxic megacolon. So, the picture is pretty self-explanatory. So now we go into common diagnostic testing, right? And so there's different things that are used for diagnostic testing, but we have what's called lab tests, right? They range from stool cultures to gastric secretions and serum levels and panels, et cetera, right? They're one of the most common evaluations and analytical procedures that are done for UC and for Crohn's disease, for IBD as a whole, because stool cultures, of course, especially with patients that have diarrhea, what's being analyzed is how much electrolytes is in your stool samples, and whether or not whether or not nutrients are being absorbed or otherwise, right? And what nutrients are not, because sometimes you'll get nutrients that you'll still be able to absorb, and sometimes you won't as a result of IBD. So now you also have gastric secretions, right? And the reason why that's important is because they want to check to make sure your gastric enzymes are still being produced, and they want to check pancreatic function usually. So for those of you who don't know, our pancreas, when it comes to our organ systems, our pancreas serves two different organ systems in our bodies. Pancreas is part of the endocrine system, which of course is part of that's our hormones. It also serves as is part of our digestive system as well. Our pancreatic, cells or what have you, they also help with digestion. And there's serum levels and panels also. Now we have imaging, right? Oftentimes imaging, CT scan, MRIs, ultrasounds, the whole nine, right? Now imaging is normally necessary whenever endoscopic procedures, like for the liver and the pancreas, for example. In endoscopic procedures, the liver and the pancreas, they can't be seen. So that's where imaging technically comes into play. It'll also show, what type of colon you're looking at. So if, your mucosa is getting damaged so much to where it's it's thinning out your intestinal wall, then likely, they may diagnose you with ulcerative colitis. Or otherwise, they may do Crohn's disease if they see that, the wall is thickening so much, and then, there's a cobblestone-like effect when the inflammatory, is healing. Endoscopic procedures, right? So your typical ones is, of course, endoscopy, colonoscopy, and sigmoidoscopy. Now I want to go ahead and go into common medical treatments. As you can see here, we have different types of medical treatments. Antibiotics, immunosuppressive drugs, anti-inflammatories, etc., right? Now I even wrote a few. You may have even seen commercials for these, So for ulcerative colitis and Crohn's disease, one of the common drugs that's used is Entyvio. So you may have seen that commercial where, it's oftentimes, a lady who's, holding her stomach has to get up, in the middle of an outing or whatever, has to go use the bathroom, or oftentimes travels with special effects they put in the videos, usually has a toilet traveling with them, that they're sitting on. Ulcerative colitis and Crohn's, Entyvio is a common drug used for both, but for ulcerative colitis, osalazine and prednisone. So those are the common drugs for those. For Crohn's disease, besides Entyvio, you also have Humira, Trimfia, and Skyrizi, which you may have also seen commercials for too. And they, like I said, they range from all three of these different types, right? I believe like osalazine, for example, is immunosuppressive, because what happens is, since IBD is the result of an inflammatory response, right? What happens is oftentimes, the inflammatory cells that get produced, what happens is with like your immune system, your immune response, basically, it gets suppressed. So that's why it would be an immunosuppressive drug. Overall, it sort of inhibits your immune response to help with, the stomach pain you may have, diarrhea, anything like that is related to IBD. You got to be careful with certain, scheduled drugs, because oftentimes, steroids especially, patients can end up developing a dependency. Now surgery, it depends on the severity of cases. So I wrote here, you have what's called a colectomy. And that's the most common type of surgery done with IBD patients. So you have three different types, usually, common types. Partial, a total, or you have a proctocolectomy. Now, in a partial colectomy, that's usually where just a part of your colon is removed. The part of your colon that's damaged so badly, they'll just simply cut that part of your colon out and then connect the healthy ends back together. A total colectomy is basically where, your entire colon is removed. Normally what surgeons will do is a surgeon will take your small intestine and connect it to your rectum, right? Because in a total colectomy, you may not have a colon anymore, your large intestine is gone, but you still have a small intestine and you still got your rectum. Usually, it's assumed in a total colectomy that your rectum is not to be touched. You still have a healthy rectum usually. In a proctocolectomy now, that is where your colon as well as your rectum gets entirely removed. So in these procedures, surgeons normally will take the end of your small intestine and then simply stitch it, to your anal canal. That way there's still a way for waste to travel through. So what happens is there's what's called I think it's a J pouch. It's in the shape of a J. That's why they call it a J pouch, or like a ilioanal pouch or ilio pouch. They all mean the same thing, but it's in the shape of a J. So they'll essentially insert a pouch that connects, they'll stitch the end of your small intestine to the anal canal, right? And it's in the form of a J, still allowing for, stuff to travel through. In an even more severe case, you may even face a colostomy. And I think, some of us know what that is, but basically colostomy, it's not always the case that a bag needs to be attached with you, but sometimes you may see like colostomy patients may have a colostomy bag for waste to, pass through. And then the bag, of course, has to be emptied after, so often, because waste has to travel. Well, waste has to, come out somewhere. There's also colostomy surgeries where just like a small, I think it's called a stoma, where like an incision in the abdominal wall is made and it's attached to the outside of the anus. You know what I'm saying? So there's not always a bag that's attached, that comes with a colostomy surgery. We're gonna go on to common nutrition therapy after talking about medical treatments. Now this is figure 15.4. And what I brought this up for was because, in IBD patients, as I mentioned a little bit earlier, I think I touched briefly on it, but there's nutrition deficiencies, right? Certain nutrient deficiencies come as a result of, IBD folks not being able to absorb all the nutrients. The nutrient deficiency and the probable cause. Protein, you can see fluid and electrolytes for obvious reasons, especially if diarrhea is a part of the IBD that you may be experiencing. And then you got iron, you have magnesium and zinc, calcium and vitamin D, B12, folate. Then you got water-soluble vitamins, which are basically your B vitamins and your C vitamins, right? So your beta carotene, your niacin, riboflavin, all of that. And then you have your fat-soluble vitamins, which is vitamins A, D, E, and K. Now, I have a whole session about that. It's session 103. Nutrition therapy commonly may require supplementation. And normally in deficiency cases, when it comes to certain nutrients, when you have to take a supplement, it's usually in a much higher dose than, the average individual would have to, consume. Thing is though, there's still, depending on the nutrient, when it comes to supplementation versus getting it from food, they may not always be equal when it comes to quantity. And also, what may happen here is removing certain, certain like nutritional values of foods. So like removing fiber, removing lactose, and high gas producing foods. That also may be, that's to start out, that's, just like with IBS, certain foods get removed, right? It comes in phases, if you remember from our previous video about IBS. So this kind of works in a similar way. So spicy foods, fried foods, caffeine, things like that will get phased out. Reintroducing fiber and lactose, that'll come in the picture just to kind of see how an individual responds to it, just to see what is a trigger for them, right? And then, as you can imagine, a plan is created to understand like what foods you can and cannot have. Protein intake of upwards of 1 to 2 to 2.0 grams per kilogram of body weight. That's going to be recommended if a patient is in intensive care for IBD. People with IBD usually get deficient in protein, which is of course not a great thing at all because, if you remember from my proteins video, proteins are made up of amino acids. Each of us have what's called an amino acid profile, every individual. Each amino acid in the profile determines how well something is done in our bodies. The blood to the tissues, or oxygen, to the tissues. Also, there's cellular reproduction, right? Amino acids help with that. And when you're not getting enough protein, as a result of IBD, that can certainly be a problem for you. Because less protein means, other things get affected too. And then you have, of course, fluid and electrolytes. If you saw my minerals video, my major minerals video, which was 103C, I talked about certain electrolytes. Sodium and potassium are our main two, okay? So when you're not getting enough potassium and sodium, because one of the things that's common with diarrhea is, you don't have electrolytes because they're not keeping any, right? There's malabsorption there. A plan essentially will be made for you to see what it is that you can have and what you can't have, just like with IBS. That right there is going to conclude 302C. This has been inflammatory bowel disease, and this will conclude this sub-series of digestive tract disorders. I wanted to create this sub-series to kind of go over the 3 different types of, commonly experienced, digestive tract disorders. So most people do experience GERD or IBS or IBD, usually in the form of ulcerative colitis or Crohn's disease. But when it comes to IBD, that's not to say men don't experience it, but women, they experience it at a higher rate. Especially when it comes to Crohn's disease, if I'm remembering right. I hope y'all enjoyed this video though. Go ahead and give it a like if you did like it, right? If you enjoyed it. And also feel free to comment if you have any questions, comments, or concerns. And also, most importantly, don't forget to subscribe. Thank you very much. I will see y'all on my next video, and have yourselves a great day or night, whatever time it is for you. Take care.